So we'll talk about a little bit about, what is Parkinson's, how do you get it, and what are the medicines that we use in Parkinson's disease, and specifically off periods. Today now we have all of these new medicines, and so we should learn how to use them. And what happens in PD is that you guys are so nice. You come into the clinic and we ask you, how are you doing? And you always say, fine, I'm okay. And that was fine 10, 15 years ago when we just had Sinemet and Azilect and nothing else. But today we have all of these new drugs. So you should speak up and complain a little bit more and let us know what you're not able to do anymore that you want to do. And so that's why we're going to talk about off periods specifically and how to treat them. And then my disclosures, I consult for virtually every company that has to do with Parkinson's disease and most of these medicines. And so what happens in PD? So that there's cells deep in the brain. This is the substantia nigra, that's called sort of the black substance. And for whatever reason, these cells start to die off in Parkinson's disease. So here we see a patient who has a normal brain, a normal substantia nigra. We see that it's nice and filled in and it's dark. And here's a patient that has Parkinson's disease. They've continued to lose those dopamine producing cells. And by the time you guys have what we call the motor symptoms of PD, those are things like a tremor, although 50% of PD patients never develop that classic resting tremor. What we call bradykinesia or slowness of movement, the trouble with gait and balance, 60 to 70% of these cells have already died off. So you've already had PD 10 or 15 years before you ever see the neurologist. And those are things patients have problems with constipation, they have anosmia, or they lose their sense of smell. They can have a history of anxiety and or depression, and they have something called RBD or REM sleep behavior disorder. And what RBD is that when you go to sleep and you go to REM sleep, which is your dream sleep, usually you're paralyzed so that you don't act out your dreams. But in Parkinson's disease, that paralysis doesn't take place and you're free to act out your dreams. So during REM, those PD patients, they talk, they yell, they scream, they kick and punch because they're acting out their dreams. And that is present 10, sometimes decades before your diagnosis of Parkinson's disease. And so those are what we see. And then here we see a patient with normal cells, and here we see these cells are dying off. And why is it that your neurologist is always talking about exercise? Remember that all of the medicines and surgical therapies that we have for Parkinson's disease today are purely symptomatic. They just treat the symptoms of the disease. They don't stop or reverse the progression of the disease. And because they're purely symptomatic, we always want to make sure that the benefits of the medicine outweigh the side effects of the medicine. That's why when you guys come into the office and you say, I'm fine, we're not going to change your medicines because we don't want to increase medicines that are going to make your side effects like dizziness or low blood pressure worse. So that's why your neurologist tends to be conservative. And why do we push exercise so much? Is because these little cells, remember, by the time you come and see us, you still have about 40% of those cells still living, and we want to keep them living as long as possible. And the only way we know how to do that today is we think that maybe with aerobic exercise, the exercise that makes your heart rate go up, it makes these little cells make new connections. The more connected they are, the more robust and healthy they are, the longer they live, the slower the progression of the disease. And so that's why we're always pushing exercise, and we try to maximize your medical management to try to let you exercise as much as possible. And remember that your medicines, although they make your motor symptoms of PD better, like the tremor, the rigidity, your balance, they make non-motor symptoms of PD worse. So they can lower your blood pressure, making you dizzy, making you more prone to falls. They can make you confused. They can make you hallucinate. They can make you compulsive. And so that's why we always want to make sure that the benefits outweigh the side effects. And then here's the famous Lewy body. Many times you've heard about Lewy bodies in Parkinson's disease. This is what the Lewy body looks like under the microscope. And this is what sort of gloms up the cell and causes it to die. This is where this misfolded alpha-synuclein, because the body can't get rid of it, it puts it in this little garbage can that we call a Lewy body. And then that's what we see in these cells here and what causes them to die. So that's sort of what PD looks like. Oh, and I was going to ask you, now you saw the answer. Well, what's the only mammal that has a pale substantia nigra? So think of a mammal that's slow, stiff, and rigid, and only has a bowel movement once a week. And then you saw, it's the three-toed sloth of South America. He's the only mammal that has a pale substantia nigra. So he's a little bit Parkinsonian. So that's why if you to take the neurology boards, you can get some extra credit and get that answer right. And so we sort of went through this. And then we talked about when you come and see the neurologist, you're over here. Your therapeutic window is quite large, and your doctor starts you on Sinemet or carbidopa, levodopa 3 times a day. And even though the half-life of Sinemet is only 90 minutes, you don't even notice if you missed that noon dose or if you ate a hamburger during lunch. Nothing happens. You don't even notice whether the medicine kicked in or not, or wearing off, and you say, well, what's this wearing off business? I don't really understand what it is. So that's because this therapeutic window is quite large, because you still have 40% of those cells still living. But as those cells continue to die off, this window gets smaller and smaller and smaller. And you can see when we use oral medicines that you start to peak and trough above and below this therapeutic window. And that's when patients start to notice that they have on time, but then they have involuntary movements, what we call dyskinesia. And once that pill wears off, they have off periods where they notice those motor symptoms and non-motor symptoms come back. Your tremor comes back, your rigidity comes back. And so what I tell patients, sort of an easy way to remember this, is that when you first come to see me, you've got savings account of dopamine, which is those dopamine producing cells that are still living. And you have a checking account of dopamine, which is the medication I'm going to give you. So initially, during that, you still have that savings account of those 40% of those cells, and they last about 4 to 6 years. So when that medicine wears off, you take that overdraft comes out of your savings account. And so you don't notice it. You don't notice that you were off. Everything works fine. Taking the medicine 3 times a day is not a problem. But 5, 6 years later, we're over here. And every time this medicine wears off, this overdraft is no longer able to be taken care of by your savings account, because the savings account is depleted. And so you notice that now the medicine has worn off, and we have to replace the dopamine, need another paycheck in there to have more dopamine in the system. And our goal is to keep you in this therapeutic window, even though it gets smaller and smaller. And how do we do that? We do that by using once-a-day medicines and longer acting versions of your levodopa, so that we don't have to peak and trough so many times a day. So any questions that you guys have about this therapeutic window? Any questions so far?
I don't see any coming through yet.
Okay, so we'll keep going. What else happens in Parkinson's disease? You have bradykinesia, or slowness of movement. Remember that translates into all of the muscles of the body, including the muscles of the gut. And because your gut is moving slower, it's the reason PD patients have constipation, where fluid gets sucked out of the gut, out of the stool, and the stool gets hard and you get constipated. And then once you're constipated, that gastrocolic reflex doesn't work, and you swallow, whether it's your pills or your food, and they sit here in that stomach for an hour or two. And so you said, like, oh, I took my medicine, it seems like nothing happened. Because this medicine has to be translated, or it has to be migrated into the small intestine where it's actually getting absorbed. And if it spends a long time here, then you notice that as a delayed on. And that's the reason why it's so important to treat your constipation in PD, so that the gut moves faster and normally, and so that everything doesn't get stuck here. So here's a patient who took this yellow Sinemet an hour and a half before this picture was taken. So here, this pill might as well be sitting on your kitchen counter, because it's not doing anything sitting in the stomach. We have to migrate it into the small intestine where it actually gets absorbed. So that's why your neurologist is always talking about constipation, always talking about increasing the fiber and fluids in your diet and adding more Miralax to your diet, taking that every day, so that your gut is moving and these pills are migrating from the stomach into the small intestine in a sort of quicker manner, in 30 minutes instead of 2 hours. And so let's clarify. So I don't know, there's probably patients here who've had PD 15 years and patients who are newly diagnosed, so that we can all get on the same page. We all have the same vocabulary. So when we say a patient is on, that means that your medication is working and your PD symptoms are well controlled. So your tremor, rigidity, slowness of of movement, your balance is better. And then when you go off, your PD symptoms have returned, even though you may have taken your medication on time. And that includes both your motor and non-motor symptoms. So your motor symptoms are sort of your classic PD symptoms, tremor. Although remember that we said that 50% of PD patients never develop that classic resting tremor. Bradykinesia, or slowness of movement. You can have poor balance, a soft speech or hypophonic speech, trouble swallowing, and difficulty with fine motor movements. But many times before your motor symptoms return, the non-motor symptoms appear. So before your tremor comes back, many patients have anxiety, or they call it the willies, or some patients have a frank panic attack. You can have more fatigue. You can have a change in mood, like more depression or anxiety. And just like you can have bradykinesia, which means slowness of movement, you can have bradyphrenia, slowness of thinking. So many times it's the caregiver who says, gosh, I know when the meds are wearing off because I'll ask him a question and he sort of stares at me blanking, and it takes a long time to answer the question. And that's bradyphrenia, and can happen before the bradykinesia, or slowness of movement, comes back. You can have restlessness and you can have pain as well. So it's important to recognize your off symptoms, whether they're motor and non-motor, and to take your next dose whenever that happens. Because think of your levodopa, it's like gas in the car. So if you drive your car at 80 miles an hour, it's going to use up more gas than if you drive at 50 miles an hour. And that's why you notice that every day is different. Some days your medicines last longer than others. They last 3 to 4 hours, no problem. And some days they only last 2 to 3 hours. And that all depends what you're doing. So if you're physically stressing your body, you went to rock steady boxing, you went to physical therapy, or you're stressed about paying your taxes, your grandkids came to visit and they're kind of loud and noisy, all of that's going to burn through your levodopa faster, and you notice that it doesn't last as long as it used to. So what's the most common type of wearing off? We call it end of dose wearing off, and it's the most common reason why your doctor increases your medicine. If you're taking Sinemet 3 times a day, they're going to go from 3 to 4 times a day, or they may add another medicine. And that's when you come in and you say, gosh, my medicine used to last 4 hours, no problem, but now 30 to 40 minutes before my next dose, I notice that I get anxious, that my tremor comes back, that I have more trouble with balance, and it just doesn't seem to last as long. So that's what we call end of dose wearing off. And so when it doesn't last as long, then we have to increase your medicine. And we see that the little sloth, he just doesn't quite get to the end as he used to. So again, that's your savings account. We've started to deplete your savings account of dopamine. And now you notice the overdraft because there's nobody to cover it. And so once the metabolism of the pill has occurred, then you notice your off period. So it's a reason why your neurologist will treat you, will say, well, instead of using Sinemet, let's use Rytari, a longer acting form of levodopa, so it doesn't wear off so quickly. You're delayed on. So remember that we talked about the gastroparesis, that slowed gut, where that pill gets stuck in the stomach and it spends more time in the stomach than it should. And so you notice that there's a delayed in absorption of the medicine. And so that can occur either because you're constipated. So once you're constipated, usually what happens is you eat something and then the stomach tells the rest of the GI system, hey, I need to push everything forward because I'm digesting this food and it's all going to come forward. But if you haven't had a bowel movement in 3 or 4 days, the colon says, hey, hold up, I'm still full over here, so back everything up, and everything gets sort of stuck up there. So that instead of taking 30 minutes to migrate from your stomach into the small intestine, it takes about 2 hours. You notice that as a delayed on. And the other thing that patients might notice is that if they eat a large protein-rich meal, that protein delays the absorption of your levodopa. So many times if patients are taking the medicine every 2 hours, then we say, well, why don't you eat your food, take your medicine first and then eat afterwards, or save most of your protein for the end of the day, or we can change your medicine. So is there a question up there?
Yes, there's one in the chat.
Okay.
My doctor's considering putting me on Rytari. I'm concerned about the side effects.
Yeah. So Rytari is the same carbidopa-levodopa as your Sinemet, this yellow pill right here. The only difference is that it has little microbeads of extended release and immediate release levodopa. The side effects are exactly the same, and we have a slide that talks about Rytari. But the side effects of your Rytari are the same as they are for Sinemet or carbidopa-levodopa. And remember that all of your PD medicines, they make your motor symptoms of PD better. Tremor, rigidity, gait, and balance, they make non-motor symptoms worse. So they lower your blood pressure, which can make you dizzy, which can make you prone to falls. They can make you compulsive. They can make you confused. They can make you hallucinate. And so always we want to get that balance just right, that you have enough meds on board, that you're mobile, but not so much that you feel like you're going to faint every time you stand up, that you're doing lots of one-click shopping on Amazon and you're up all night, or that you're having some hallucinations that are bothersome to you. So always we want to get that balance right, because these medicines are purely symptomatic. Remember that we said that only exercise, we think, may slow down the disease progression. Then morning off. So remember, you're taking your medicines throughout the day, and then patients go to sleep at night and don't take any medicines. So when they wake up, their gas tank is empty and there isn't any gas in the tank, and it takes a long time for that first dose of medicine to kick in. And so we call that a morning off. So we can treat that by using medicines that are 24 hours. So they cover you not only during the day, but at night. We can add a dose of levodopa in the middle of the night, or we can use an on-demand therapy with your first dose of levodopa, something that bypasses the gut, so it kicks in faster while your pill is migrating through that GI system. And we'll go through all three of the on-demand therapies a little bit later on. And then your unpredictable offs. Remember how we said that your levodopa is like gas in the car? So depending on what you're doing, that depends how quickly you're burning through your levodopa. So if you're going to rock steady boxing, you're exercising, you know, you live in Phoenix and it's 100 degrees outside, or you have a UTI or a bladder infection, all of that can stress the body and cause you to burn through that levodopa faster, and you can have an unpredictable off. So a dose that usually lasts 3 or 4 hours, no problem. If you stress the body, then it may only last 2 to 3 hours. And then that's a good time to take one of these on-demand therapies, and we'll talk about them a little bit later. So any other questions about these different types of offs?
Yep, so there's a couple other ones.
Okay.
You mentioned pain as one of the motor symptoms. What or where is the pain?
So pain is part of the non-motor symptoms, and PD patients can have pain from dystonia. So dystonia means an abnormal contraction of a muscle. That can be any muscle in the body, but many times it's your foot turning in. You can have neck pain, a cervical dystonia. And so that can be, so if your muscle gets rigid and stiff and it can't relax, then that can be painful, and that can be part of your off period. And then soon as you take your medicine, it kind of melts away. And that's how we know that the pain is related to the Parkinson's disease and not to things like arthritis or what we call TMB, too many birthdays, another chronic and progressive disorder. And so if it waxes and wanes with your medication, then we know it's the Parkinson's disease. If it's there all the time, then it could be sciatica or arthritis or something else. What was the other question?
Yeah, one says, thank you. I have done well on side effects with Sinemet, considering a trial for a few days.
So they're considering a trial of levodopa for a few days, or?
And then there's another one that says, I do. Those were the other two that were in there.
What's that?
That's all that was in there.
Oh, okay. So let's go through the medicines that we currently have. So this sort of box over here, these are all the dopamine agonists. So remember, your carbidopa, levodopa, that levodopa turns into dopamine in the brain, exactly the same chemical that's missing. The dopamine agonists, they go and they sit on the same receptors as dopamine, but chemically they're not the same chemical. And the nice thing about the dopamine agonists is that there's once-a-day versions of all of them, and there's even a patch for rotigotine or the Nupro patch. So it's a nice way to cover patients throughout the morning, during the day, and at night. And so that you don't wake up with as much morning off because you already have a floor there, so you don't ramp up from 0 in the morning. The problem with the agonists is that they have lots of side effects early on. So patients are more likely to have compulsive disorders on dopamine agonists, more likely to hallucinate on dopamine agonist. And so we always want to be careful using high doses of the agonist. Nupro or rotigotine is a patch, so we bypass the gut. We don't have to worry so much about whether you're constipated or not, or you have gastroparesis or that slowed gut. So the patch is a nice option for us as well. These ropinirole and pramipexole are generic, although their price is not generic. So sometimes it's a little bit more difficult for us to get patients on these. Either the insurance will say no, or they can be expensive. And so we'll have to go to the ones that are 3 times a day. And then many of our patients get these drugs from Canada, where, you know, a 90-day supply is what you would pay for these medicines for a 1-month supply here. And then rosagiline and Xadago, these are MAOB inhibitors. So remember that there's 2 enzymes in the gut that sort of block or chew up the levodopa, and then there's one enzyme that in the brain that chews it up. So what the MAOB inhibitors do is they inhibit the metabolism of dopamine once it gets up into the brain, so it makes it last longer. And rosagiline or sulfonamide is the generic of this, is Xadago, are 2 MAOB inhibitors. They're both once a day. Very well tolerated, very few side effects that we can use for patients. And then rosagiline is also approved as a as a medicine, even if you're not on levodopa, just like the dopamine agonists are, or you can add them into patients who are taking levodopa. Then Ongentys, so remember you have carbidopa, levodopa. That carbidopa is there to block an enzyme in the periphery that chews up your levodopa. And so if we didn't have that carbidopa there, we would have to add way more levodopa to get it up into the brain. As it is, that yellow pill that you're currently taking, it's only 1 to 5% of that levodopa makes it from your gut into the brain. It's almost nothing. And if we had to take away that carbidopa, instead of giving you 100 milligrams, we'd have to give you a whole gram of levodopa. Patients would get very nauseous and vomit and not tolerate it very well. So every formulation has carbidopa. And then Ongentys or opicapone is a COMT inhibitor that blocks the other enzyme that kind of chews up your levodopa in the periphery, so that once we're on both of those enzymes, more of the levodopa is going to make it into the brain, and then we can block the metabolism of that drug, of the dopamine with the MAOB inhibitors. The Norians is a drug. So think of all of these are kind of like the gas in the system. We're putting more gas in the system and to make the car go where we want it to go. And when we add Norians, that's also a once-a-day medicine, but it doesn't act through the gas in the system. Think of it, it takes the handbrake off the car. So even though we run out of levodopa, we ran out of gas, if we take the handbrake off, then we can still coast down the highway once you've worn off. So it's another mechanism, another way to treat Parkinson's disease that's not through the gas, it's through the brake system. And so we use that quite a bit as well. And it's once a day, very well tolerated as well. And then Gocovri is a form of amantadine that we use in patients who develop peak dose dyskinesia. So you have those involuntary movements once you peak above your therapeutic window. And then it also helps treat our off periods. And these are all once a day medicines. Remember, the less times that you have to swallow a pill in Parkinson's disease, the better off you are because of the gastroparesis. And so we're less likely to get stuck in the stomach. So if we can take these once a day, we're better off than taking it 3 times a day. Although in the past we used amantadine, which is the generic, and that's a medicine that we take 3 times a day, and Gocovri is a once a day medicine. Again, if we take medicines once a day, we again get less side effects. So any questions about these adjunct medicines for PD? No. Okay, so we'll talk about what longer acting formulations of levodopa. So we talked about Rytary and then Duopa, which is a pump. So Rytary is a capsule. So your Sinemet is a tablet and the Rytary is a capsule, and it has A third of these little microbeads are immediate release and the other 2/3 are extended release. So it's going to hang out in your small intestine for 4 to 5 hours, a longer period of time. So it absorbs over a longer period of time and it has a longer half-life. And then we also have 4 different doses of Rytary. So it's easier for us to sort of mix and match and get, better therapy. So we've got 95 milligram tablets or capsules, 145, 195s, and 245s. The other thing is that it's a capsule, so we can open that capsule up. If you have trouble swallowing, then instead of cutting the pill in half, and remember, if you're taking a once-a-day medicine, it's not going to be scored because you can't cut those medicines in half. Once you cut them in half, then they're not extended release anymore. But these Rytary capsules, if you have trouble swallowing, then we can open up, especially these are kind of quite large. You just open it up, put it into a spoonful of yogurt or applesauce, and then take it that way. Don't dump it into the whole yogurt because then you have to eat the whole yogurt to get the full dose. So just put it into a spoonful of yogurt or applesauce, and that way it's easier to swallow when these pills get big. And then there's going to be a new version of Rytary. It doesn't have a name yet. It just has a number. It's called IPX203. And if it's approved by the FDA, that'll be available in the summer, late summer months. And it'll be a longer acting form of Rytary. So we might get 6 to 8 hours out of each dose. And again, we want to be in the longest form of Levodopa that we can get our hands off on so that we only peak and trough X amount of times during the day. Remember, every time you peak and trough, your kind of day stops and you're waiting for that on time to go back on again. And what we don't want is patients sort of planning their day over with each dose of Levodopa. Because once you start to plan your day around each dose, you stop doing stuff because then you say, gosh, I never know when my pill's going to kick in and how long it's going to last. And because I don't know those things and I don't want to get stuck outside, I'm not going to go to brunch, I'm not going to play golf. So we want to minimize that as much as possible because 90% of our medicines for PD are still pills. That's our biggest problem. Then we've got the pumps. So why use a pump? We use a pump when patients come in and tell us exactly that same thing. I never know when my pill's going to kick in and how long it's going to last. And I'm planning my day around every single dose of Levodopa. And we saw that therapeutic window. And once you're advanced, once that you've lost all of those dopamine producing cells and all of that on time is only coming from the medication, it becomes quite small. It's only 90 minutes. And then you peak and then you spend the rest of the time above it with dyskinesia or extra movements or below it with off time. And so the only way to really keep you in that sweet spot is by using a pump. So with a pump, we have much greater control over your dose. So the Duopa pump, it gives you a little squirt of Levodopa every 57 seconds. And it has a little peg J that goes into the stomach. And so it's always hanging out in the small intestine, the jejunum, where it's actually getting absorbed. So it doesn't matter so much what you ate, when you ate, because your Levodopa is always first in line to be absorbed. And if you ate a big meal or lots of protein, there's an extra dose button that you can add a little extra medicine. Or if you became dyskinetic and had lots of extra movements, if you're on Rytary, then we have to wait the 4 to 5 hours that it'll take for that pill to be metabolized and then you're dyskinetic the whole time and we can't get that pill back. But if you're in a pump and you accidentally gave yourself too many extra dose buttons because you had a big meal or you went to exercise and overdosed a little bit, then all you have to do is turn down your continuous rate or turn off the pump, and then you fall back into this therapeutic window in about 20 minutes. So you have much more control over your dose with a pump than you do with a pill. And as you can see, it's much easier this way. You're not peaking and troughing every 3 or 4 hours with a pump. So this is what it looks like. Here's your pump. Here's the cassette that carries the Levodopa. This cassette you keep in the fridge while it's not in use, and then you take it out every morning. You let it thaw out for about 20 minutes in Milwaukee and about 2 minutes in Arizona, and then you plug it in, and then you start your pump. It's 2 of these morning dose, like 2 cups of coffee. And here you see there's an extra dose button, so if you need it. And then you connect it to your peg J, And this little tube goes into the tummy and into the jejunum, where it's always going to, your levodopa is always first in line to be absorbed by the small intestine. So we don't have to worry so much of what you're eating when you're eating, because the levodopa is there. And this is kind of what it looks like. And then here we see that patients
we have a couple. Okay.
Yep, go ahead.
Okay, I think you just answered one of them. So
Mhm.
how does that affect eating schedules, Rytari? I think you just answered that. I cut out a little bit. Sorry about that.
Okay. Yep. And so, yeah, so with the pump, it's not so critical of what you eat or where you eat it. And if you're on the longer acting form of the medicine, like Rytari or IPX203, again, it's not so critical because it has those little microbeads that are going to be hanging out in your small intestine, getting absorbed over the 4 to 5 hours, not competing in that 90-minute window with the protein in your food. And then here we see what the pharmacokinetics of Duopa looks like. So you give yourself a morning bolus in the morning. Remember, in the United States, it's only approved for 16 hours, although half of my clinic uses it over 24 hours. But you would use a morning dose, a morning bolus. Remember how we said that some patients take an on-demand therapy first thing in the morning? So that's sort of built in here. Then you go on, and then you go on your continuous dose, and you can see how sort of nice and steady this is. It's not those peaks and troughs that we saw with the oral medicines. It's nice and steady until you turn the pump off. And then, of course, then you start to wear off. And then we'll treat patients with Rytari or longer acting form of levodopa at bedtime, or again in the middle of the night to keep you on. So this is sort of what we want to have with patients. Right now, the only way to achieve that is through Duopa. But this year, we're going to get 3 new pumps that are sub-Q pumps, or subcutaneous pumps, so they won't require the PEG-J. Oh, this is how patients always ask, well, like, where am I going to put this? How do I wear it? So many people use this sort of, this like kind of fanny pack. This is also good, but in Arizona, it's way too hot in the summer. And you can wear a dress. There's also a bra that you can get on Amazon that has a pocket, and patients put it in there. I even have one patient who's a male patient who uses the bra. And then patients also ask, well, what if I want to go swimming or, play golf or, just be off the pump? And that's not a problem. You just disconnect the pump. And if you're off the pump for less than 2 hours, you don't need any extra medicine. If you're off more than 2 hours, then we give you a dose of oral medicines. But if you wanted to go swimming or do any of those sorts of things, you can unplug the pump, and you can also travel with the pump as well. So you just, Avi will give you a little cooler where you keep your medicines, and then they have a little card that tells TSA that you have a medical device and that this is your medicine, and that's not a problem to travel with. And this is what the future looks like. So we see that it's smaller. So Neuroderm is going to be one of the levodopa pumps. It'll be probably the last one to come out this year or early next year. And then Supernus will have an apomorphine pump. So remember that we talked about ropinirole and pramipexole and the Nupropatch. Those are all dopamine agonists. Apomorphine is a dopamine agonist. And this is what the apomorphine pump looks like. And it's been available in Europe for 30 years. It's been used quite successfully. So like a type 1 diabetic pump, instead of having the PEG-J, nothing's going into the tummy, into the small intestine. It's all subcutaneous. It has this little Band-Aid. It has a little cannula that goes into the subcutaneous skin. And you move that around every 3 days. And then you change this syringe once a day that has your levodopa in it. And then these are quite easy, intuitive to use. So this is what the future looks like. Smaller pumps, no longer requires the PEG-J. And then it would be subcutaneous like the type 1 diabetic insulin pump. In the clinical trials, some patients did develop an allergic reaction to the levodopa under the skin. So some patients discontinued the trial because of that, and then they would have the option either to go back to oral medicines or to go on Duopa, and then they could tolerate that quite well. And then at 951, the Avi pump, of course, they wouldn't let us use one of their pictures, but that will be probably the first pump that will come out, will be the Avi pump. And if we're lucky, it should be out by August, if approved by the FDA. So any questions about the new pumps that are coming out this year?
Not specifically about that, but there is one. Will this webinar be available to review? There's a lot of information to assimilate so fast. It's very informative. So yes, this will be on YouTube later this week and early next week. It is being recorded, so I can answer that one. And then, and then we have another one in here. Do people mix and match Rytary dose levels to get through an off time?
Yes. So remember, your people mix and match Duopa, the pump with oral medicines, Sinemet and Rytary. So it's exactly the same levodopa. It's just a different formulation of levodopa, and you can mix and match and use whatever works for you. So patients can be on the pump and take oral medicines. You can be on Rytary and take yellow Sinemet in between your doses. That is perfectly okay. Or you can take Inbrija, an inhaled form of levodopa. That is fine as well. So remember that levodopa is very forgiving. Too little levodopa, you're slow, stiff, and rigid. Too much levodopa, you're dyskinetic or wiggly. You can hallucinate, but that goes away once the pills metabolize. So we don't get too exercised. If you forgot a dose or you took an extra dose, there's no need to go to the ER. We don't want to double up on any of your other PD medicines. So your dopamine agonists, we don't want to double up on those. Your once a day Gocovri, Picapones, Gentis, we don't want Norians, we don't want to double up on those. But the levodopa is quite forgiving, and you can mix and match. And so we also have on the,
excuse me, Dr. Ospina, we have a couple more. Do you want me to hold or do you?
No, go ahead.
Okay, great. So did patients require or use any on-demand therapy while using the pumps?
Yeah.
And then one other one, at what stage do you start using the pump?
So any patient who's taking Sinemet or levodopa more than 4 times a day is a pump appropriate patient. So if you're going to go to 5, 6, 7, 8 doses of levodopa, you might as well be on a pump, because why peak and trough 6, 7, 8 times a day? That's 6, 7, 8 times that your body is wearing off, shutting down, and you have to restart it again and restart your day. What we want is that your day looks like this, that you start your day and that you're on all day long, that you're not shutting on and off throughout the day, and that you only shut off once you turn the pump off. Or you can keep, like I said in my clinic, even though Duopa is only approved for 16 hours in the United States, half of my patients keep their pump on 24 hours a day. You can't, so the pump does have, the current Duopa pump, this little button here is an extra dose button. So it has an on-demand therapy built into it. So those patients don't usually need to use Inbrija or an on-demand or rescue medicine, but you could certainly, I know in the Supernus trial, many of these patients used apomorphine. We're going to talk about that injection, this one, Apokin, throughout the trial as their on-demand therapy. So all the pumps will have an on-demand therapy or extra dose button, but you can also use extra medicine, whether it's yellow Sinemet or Rytary or on-demand therapy. So we'll talk about the rescue medicine. So there's 3 of them on the market now. And that's why I tell patients, don't be so nice. When you go into your doctor's office, you need to complain and say the things that aren't working. Just because you've had PD for 10 years and now you've gone used to that, it takes you 2 hours to get ready in the morning, get dressed and bathe and have breakfast, that it didn't used to take you 2 hours, that, when you had a body that had enough gas in the tank, you could get ready in 20 or 30 minutes. And today you can do that as well. So you can use your on-demand therapy while you're waiting for that oral dose of levodopa to kick in and be up and about a little bit faster. Or if you get stuck in the middle of your golf game or your middle of your rock steady boxing, remember we talked about that unpredictable off, that you can use one of these rescue medicine or on-demand therapies to get you through those off times. So we'll look at Inbrija first. So Inbrija is an inhaled form of levodopa, and it bypasses the gut. Remember, the gut in PD is slow, patients are constipated, that gastrocolic reflex isn't working, you swallow that pill and sometimes it stays there for 2 hours in the stomach. So in those patients, we can bypass that stomach altogether and we can inhale the levodopa through the lungs and kick in 5 to 10 minutes. And the problem with all the on-demand therapies is that they only last about an hour, but you can take them up to 5 times a day. So it's not something that's going to get, it's a real dose, but it's a rescue dose that gets you from one dose to the next. So you inhale the levodopa. Many patients will have a trouble with a cough for the first couple of weeks because they're not, our PD patients aren't smokers. And so they'll cough it out. But once you get used to the cough, then you'll find that it kicks in 5 to 10 minutes, lasts about an hour. And many times we'll tell patients, it's not like an asthma inhaler. You don't go a big swift inhale. It's slow and steady. You take a little sip of water before and during to minimize that cough. And that one dose, or with a full dose, is 2 capsules of these. So many patients only take one and say, oh, it didn't really work. It's actually 2 capsules. 2 capsules equals one of your yellow cinnamons. Then there's Kynmobi. So Kynmobi and Apokyn are both apomorphine. Remember, apomorphine is a dopamine agonist. So it goes and it sits on the same receptors as dopamine, but it's not chemically the same chemical. And it's a little film that you put under the tongue and it absorbs in the oral mucosa. Again, same thing in 5 to 10 minutes, and it lasts about an hour. The apomorphine, whether you take it as the sublingual film or the Apokyn injection, we have to titrate it because it causes low blood pressure and it can cause nausea in patients. So we start at 10 milligrams and then slowly go up. Most patients end up in 20 or 25 milligram sublingual films. And then they can take that up to 5 times a day. So it's another way to take the medicine. Some patients have oral blisters and then they discontinue it for that reason. There's not a cough, but some people have some blisters. And so they notice that when they brush their teeth, it's uncomfortable. So they can try Apokyn, which is the injection. So this is by far the fastest acting and most reliable on-demand therapy because it's in a sub-Q injection. So just like the pumps, it goes into the subcutaneous skin and it kicks in 2 to 3 minutes and it lasts about an hour. Again, because it's apomorphine, there's a titration that's needed. And a nurse will come out and help you with that. And we monitor your blood pressure and make sure that you don't get nauseous. And then patients can use that up to 5 times a day. And as we said, with the apomorphine pump, they use that frequently with their as their on-demand therapy as well. So any questions about the rescue medicines?
We do have a couple in here. So does Inbrija help non-motor symptoms as well? Are there side effects from Inbrija? I know you talked a lot about some of that, but.
Yeah, so it helps. Remember, all your PD medicines, they help your motor symptoms of PD, but they make non-motor symptoms worse. So it can make you, like apomorphine, it can make you dizzy because it lowers your blood pressure. It can cause nausea and vomiting. The Inbrija has the cough. So the most common reason why patients discontinue Inbrija is the cough. And they feel like, gosh, it's like I'm inhaling this sort of gritty powder. I don't like it. So either you get used to it and you don't cough anymore, or you go on to one of these other on-demand therapies. Any other questions? Okay. Then the surgical treatments for PD. So what's another way to treat your PD motor symptoms? Bypassing the gut. So remember that your brain has 2 ways to talk to itself. One is chemically, and that's what the medicines do. They're a chemical way to talk to your brain because it replaces dopamine. And then the other one is electrical. So the chemistry makes the electricity work and the other way around. And so DBS, or deep brain stimulation, is the electrical way to talk to your brain. And we put stimulators deep into the brain. One, remember your brain is like a walnut and it has 2 sides. We put a stimulator into each side. And in Parkinson's disease, there's 2 different targets, the SDN and the GPI. And then we connect those stimulators to a little battery pack that's here under your clavicle. And there's 3 companies that make the DBS hardware. So there's Medtronic that has Precept. There's Abbott that has remote programming. So patients who are snowbirds, if I see you in Phoenix and we program your Abbott stimulator and then you go back to Milwaukee, we can connect to your device through like an iPad and an iPhone and through kind of FaceTime, and we can program your stimulator that way. And then there's Boston Scientific that also makes DBS hardware. So DBS works really, really well for tremor that we can't control with medication, or we have to use such high doses of medicine that you have side effects like hallucinations or confusion or lots of nausea, vomiting, or dizziness. And if you have on time with dyskinesia, your medicines work, but your window of on time without extra movements or the dyskinetic movements is quite small, and you can't tolerate amantadine or Gocovri, then DBS is very good at giving you on time without the dyskinetic movements. So those are the two main reasons to use DBS. We tell patients that everything else that you get is sort of frosting on the cake, and that we're looking for those motor benefits of tremor control and dyskinesia control with DBS. Things like speech, swallowing, freezing of gait, those things are not going to improve with DBS. And the things that preclude DBS, that's why there's a window for DBS. If patients develop dementia, then they're no longer candidates for DBS. Or if you have an untreated depression, then we would treat the depression first and then consider surgery. And so that's why the preclinical workup for the DBS surgery includes on and off testing to see what your response to levodopa is, and a neuropsych test to make sure that there's not an untreated depression or that you're not sliding into dementia. Any questions about DBS? And so here we're going to see two patients with DBS. So here's a patient with tremor. This is the old DBS. It's much more sophisticated now. It talks to, we can talk to it with Bluetooth. So now she's turned the stimulator on. And remember, it's two sides, so we only control one side at a time. And she's going to slowly go. And there we see we can dial out the tremor. Okay, so we see that a fairly low voltage, although with Precept, we can get good control under 1 volts. But you can see the difference between tremor and dyskinesia. So many times patients are confused to what's a tremor, what's dyskinetic movements. If it's fast and rhythmic in an arm or a leg or the chin, that's a tremor. And now we're going to see a patient here with dyskinetic movements or wiggly movements. So here's Claire before her surgery. So we see Claire there, she has involuntary movements. They're kind of all over the place. They're kind of dance-like. And so that's dyskinesia or dyskinetic movements. And of course, Claire is under the National Healthcare System of Australia. So they get to keep her in the hospital and program her stimulator right away. In the US, some patients will get a little honeymoon period and their symptoms get better, but we don't start to program your stimulator until 4 weeks after we let all that swelling go down. And of course, we're not able to admit you to the hospital and get your programming done in 2 weeks, like they do there. And so it takes a little bit longer for us to dial out your tremor and dyskinesia than it does whether you're in Europe or Australia, where they can admit you to the hospital. But those are two examples of what DBS would allow you to do in patients who have a tremor that's uncontrolled by medication or who take medicine and then become dyskinetic. So any other questions about DBS? So what do we want to do with your medicines, and why is it important to treat your off periods? Is that we want to minimize those motor fluctuations that you have during the day so that we can bring back predictability in your day. Once your day is predictable, then patients start to do stuff. So they start to plan more things. They're not planning their day around every dose of levodopa. Of course, once the patient is doing more things, that means that the family and caregiver is also doing more things, because once the patient becomes sort of more confined to the home and more socially isolated, the same thing happens to the caregiver. There's increased caregiver burden. And so that we want to minimize that as much as possible. And so it's the reason. So it's not that you come into the clinic and we're like, oh, we're going to go and pick the most expensive medicine out there at CVS or Walgreens. Is that we're picking the medicine that most closely resembles your normal brain, your longest acting form of levodopa. Remember that your brain doesn't pulse you with dopamine every 3 or 4 hours. It gives you a continuous infusion of dopamine over the 24-hour periods, more like a pump. And so that's why we gravitate to once-a-day medicines and longer acting forms of levodopa, and then migrate to the pumps. So what questions do you guys have about medicines? I know we're kind of hitting the top of the hour here.
So there's a couple. Let's see here. Any research on using organic levodopa?
Yep. So mucuna beans. So remember how we said that yellow cinnamon, 100 milligrams of levodopa, only between
purines for
mucuna, right? So of that yellow cinnamon, that 100 milligrams, only 1 to 5% makes it from the stomach into the brain, almost nothing. And that's only because we added carbidopa to that levodopa. And so if we didn't have the carbidopa, you would have to take a whole gram of levodopa to get that 1 to 5%. And you would have lots of nausea, lots of vomiting, lots of dizziness. So with mucuna has levodopa, but doesn't have carbidopa in it. So patients have to take a much greater proportion of mucuna beans to equal what they get in their cinnamon. So cinnamon is a much more efficient way to take levodopa than mucuna beans.
Okay, thank you. There's one in here that says, my doctor says to take carbidopa, levodopa with caffeine and carbonation. What is your opinion on that?
Yep. So if we needed to kick in fast, then you take it, you can crush it and take it with a carbonated beverage. If you need it to slow down the absorption because you're dyskinetic, you can take it with milk or yogurt or something that has protein in it. But today, a patient should not be taking cinnamon 6, 7, 8 times a day. That you should be on a long-acting form of levodopa like Rytary or when IPX203 comes out, so that we don't have to worry so much of what you're eating, when you're eating it, and worry about your diet so much.
Okay. And we have a question here. You mentioned the importance of exercise, but doesn't that put stress on your body? Are there specific exercises that you would suggest?
Yeah, and so it does put stress on your body, but remember how we always said we want to make sure that the benefits of the medicine or therapy outweigh the side effects of the medicine. Then we know that the benefits of the exercise, that they help those little brain cells make new connections. So the more connected those brain cells are, the longer they live and the slower the progression of the disease. So it's worth the extra effort to do the medicine. And just like you want to have a well-balanced diet, you want to have a well-balanced exercise program so that you have aerobic exercise for the brain and you have resistance training for the muscles and the bones. So remember, you have bradykinesia, your slowness of movement. There's actually nothing physically wrong with your muscle. The muscle is totally normal. It's just that it's not moving. It's moving very slowly. And if it's moving too slowly, it starts to atrophy and waste away. And so then you lose strength. So we want resistance training to keep those muscles as strong as possible. And it turns out to have strong bones and absorb the calcium into your bones and make them strong. The muscle has to push and pull on the bone to tell the bone to absorb the calcium in your diet or your supplement and put it into the bone. If it's not getting that pushing and pulling from resistance training, then you develop osteopenia and osteoporosis. The bones get brittle. So that's why you see when the astronauts go to the space station, they're always doing that force exercise. It's because they're at zero gravity and they're developing osteopenia. And so we have to do some kind of resistance training so that they don't demineralize the bones. The same thing happens to PD patients.
Thank you. We have a couple more questions here, then we're almost at time. So one is, what does agonist mean? And then what causes a metal taste sometimes in my mouth as a side effect from carbidopa levodopa?
Yeah, so agonist just means that it does sort of the same job as dopamine. So remember we said that the dopamine agonists, they go and they sit on the same receptors as dopamine, but chemically they're not the same chemical. Whereas levodopa will actually turn into dopamine in the brain, exactly the same chemical, and go and sit on those receptors. So the dopamine agonists will sit on those receptors, but chemically they're not the same. The pluses are that there's once a day versions of all of those medicines, so it covers you day and night. The minuses are that at lower doses, they have more of those non-motor side effects like impulse control disorder, hallucinations, low blood pressure than levodopa does. So that's what a dopamine agonist does. And then many times there can be some, especially, patients who had COVID and took Paxlovid, they all had that chemical taste in their mouth. And so it just has to do a chemical reaction that causes that metallic taste. Usually carbidopa, levodopa doesn't, it's not that big of a deal like it is with antibiotics.
Thank you. And we just have one more comment here. So I just wanted to thank the good doctor. I'm coming up on 5-year anniversary of PD because I've been doing so well, attended 3 different exercise programs and meds. Life has been quite good. However, just as you said, many things can happen and things can change. This is the best explanation of meds and other processes that are available. Thank you very much.
Sure, remember that you've got that savings account. And so we want to keep that savings account living as long as possible. So that's why it's important to do the exercise. I think the rest of is the exercise, we can do that another day.
Well, Dr. Ospina, thank you so much for your time and joining us.
Sure.
I know that we may have some other webinars in the future with you, but thank you for joining us and hope you all found this informative. And we will have this on our site, on our YouTube channel in the next week or so.
Okay, you guys take care. It's nice to see everybody.
Take care, everybody. We'll see you soon.
Okay, bye-bye.
Bye.